Well, thank you, Macomb County, for joining us. And we have an excellent panel on mental health. My name is Laurie Stone. I'm the state representative for the 28th House District, which includes Western Warren and all of Centerline. And I'm serving in my second term in the Health Policy Committee. And we're seeing mental health at the intersection of so many issues. Education, health, general health, physical health, criminal justice. And so this is a very timely topic. We're also seeing reimagination of mental health access in our community. And it is more important than ever that we're getting community input, but even more so, making sure that the professionals with experience in this are weighing in on the topic and helping us shape our policy. So thank you for everyone who is joining us this evening.
Thank you.
Thanks, Rep. Stone. Good evening, everybody. My name is Felicia Brabeck, and I get to work with Rep. Stone in the House. I am the state rep for the 55th District, which is part of the city of Ann Arbor and several of the surrounding townships, and then also part of the city of Milan. And I'm also seeing that another one of our colleagues is joining us. So as soon as he does, we want to acknowledge him. Did he go away, Brooke? Did I miss him?
Nope, he's here.
Oh, there he is. We could see you coming in, Rep. Hertel, and so we're grateful that you're here. We're just getting started. Thanks for being here.
All right, thank you.
Yeah. So part of the reason why our caucus is doing this is, as Rep. Stone said, we are seeing that mental health is at the crux of so many different issues. And part of my interest in doing that is that I'm a mental health care provider. So I have my master's degree in social work and my doctorate in clinical psychology, and have been practicing in the field doing therapy with folks for over 25 years. I also got to serve as a Washtenaw County Commissioner for 9 years, and 8 of those years I was on the Community Mental Health Board. And so I have experience in both the public and the private systems, and have been standing shoulder to shoulder with many of you, advocating for different things in the community mental health system. And part of the reason why this came about was, we knew that there were a couple of packages of bills that were going to be potentially before us. And so I got together a group of stakeholders, mental health stakeholders, to ask them about what they wanted to see, what they were hoping for, what they thought the opportunity was at this point. And one of the biggest things that we kept hearing over and over again was that stakeholders felt like they were always brought in after the legislation and kind of after the fact, not at the beginning and not during. And so that's one of the things that our caucus has really tried to do differently, is talk to as many folks as we can before development of legislation. And so this is why we are going throughout the state, talking to folks, talking to experts, talking to consumers, talking to their families, talking to the providers. Health plans have been part of this. So trying to talk to as many folks to figure out how we can develop and what the real meat of the legislation can be. So I'm grateful to all of you for being here. Right now, Brooke just put up for us what the real mission of this is. And so it's, again, going around, and right now I think we have about 13 different stops that we're doing. And we're a little bit over halfway through those stops. And we're asking the same 6 questions at each of the stops, trying to get some apples to apples comparison about which hopefully will help highlight some of the differences throughout our state in terms of what needs are, so that, again, we can create some really responsive legislation. So I want to remind folks that, and most of us here know this, but I just really want to lift it up and highlight it. It's on the public mental health system side of things, we really get to focus on 3 different populations. So we get to work with residents with serious mental illness and children. So it's adults and children, those with substance use disorders, and those with developmental and intellectual disabilities. So there are 3 main groups that right now we get to work with. And so if those folks who are on the panel can kind of, keep in mind all of those different groups who we have the opportunity to work with, that would be fantastic. And we are going to put in the chat, we have a Google form with the 6 questions that we're going to be going through, plus the ability to attach a document. And it's either a document or a video. I'm grateful to my team member, Brooke, for figuring out how to do that, because we want folks to be able to communicate with us in lots of different ways. And so if someone is more comfortable doing a video, we want them to be able to have the opportunity to get that information to us. So that is in the chat. Please share with your networks. Again, we want to get as much information as we can. So please share that far and wide. And now I just want to introduce our panelists and thank them all for taking time on this Thursday evening for being here. First, we have Shelley Petty. Shelley, thanks for being here. Shelley's a consumer. We also have Sabrina Toskowski. Sabrina, thank you for being here. She's also a consumer. We have Dave Pankatai, who's the CEO of Community Mental Health Services in Macomb. We have Linda Bush, who is a CMH board member. She's the treasurer. And we have Karen Wood, who is the CEO of My Care Health Center, which is the federally qualified health center, or you might hear us refer to it as the FQHC. And so we're going to try, as we're talking, I'm also going to ask all of our experts here, our panelists here, there can be a lot of acronyms in our system. And so as we're using them, to please explain them so that everyone, we can all be on the same page with them. I know it can be easy to kind of get in our lanes here and not do the explaining that would be helpful to do. So let's jump right in. What we like to do is spend this beginning time going through those 6 questions, and then at the end we're going to open it up for other folks who are joining us to respond to any of the questions, give comments to us, and so we're going to do that at the end. And so let's hop in. So the first question that we have is, we have our CMH system. There are things that are great about our CMH system that work well with it. And so I'd like for you all to think about, what are the things that we're doing well? What do we like about the CMH system? What things would our consumers, both who are here and who aren't here, think that, yep, you get a gold star for? What are the opportunities that we have? What are ways that we might improve? And then are there any barriers? Any places where we are truly stuck, that we could lift up. And so, I'll just ask anyone on our panel here to start. You can either raise your hand, your actual hand, or your virtual hand, and then we can just keep going around, kind of round robin, to hear from all of you. But we'd like to be able to hear from all of you on these questions. Who would like to start us off? Dave, go for it, please.
I was waiting to be polite, but if anybody else would like to go first, feel free. But transportation is just a historical barrier, across our state and nationally. The telehealth services did impact that, make that more readily available. But then you get into access to technology as a possible barrier as well. And then I think there's a general lack of knowledge about all of the services that are available through the community mental health system. And some of those have just changed here recently as of the 1st of this month. So we are actively working to increase the marketing communication to the community as a whole, to our community partner agencies, to try to improve that area.
transportation and education, both of those things that you just said, Dave, have come up several times in previous listening tour stops. So it is, I'm kind of keeping track of these themes that we're hearing, of course. And so thank you for lifting those up. Who'd like to go next? What things are we doing well? What things can we see as opportunities and places where we might grow? And what things are true barriers for folks? Shelley, please.
Okay. Oh, Linda, did you want to go?
No, go ahead. I didn't raise my hand. Sorry.
Okay. Okay. I'm a parent of a consumer. So we see different sides of things, and I do agree with Dave that transportation is a huge issue, and the lack of education and knowledge of what CMH does offer. Macomb County CMH really has a lot under its umbrella. And, the thing that I do think they are doing well is the change in some of the technology and updating their websites. And that is good because it's much easier to use now than it was before. But I do also agree, like, as far as for us as a parent and some of the families that I deal with and that I help, is that lack of communication that us parents and the consumers and the families are kind of like the lowest on the, I hate to say lowest on the totem pole, but we're as far down as you get when it comes to communicating what's happening and the changes. And it just rolls out from top to bottom. And unfortunately, by the time it gets down to us or to our support coordinators, there's just a lot of misinformation. It's kind of like playing the game telephone. You hear it from one person, and then by the time it gets down to you, we're not always sure exactly what is the truth, what is not. And so I do think with that change in technology and continually updating the websites, that's a good thing. But it really is a big problem on my side of it, that a big complaint from parents.
Shelley, can I ask a follow-up question to you on that? Do you feel like that lack of communication is happening generally, or is it around the recipient rights issues?
I just think I would say more generally.
Okay. All right. That's helpful.
Mm-hmm. Yeah.
Okay. Thank you.
Yeah. With our consumers, we have some that are self-determined and some that go through agencies. And so that's where a lot of the problems lie. And I commend Dave's office for always trying to kind of get it together and keep people on the same page, but it's just been a big issue lately again. So yeah, that's
really helpful. Thank you, Shelley.
Mm-hmm.
Dave.
Yeah, if I can, I agree with Shelley. It's an ongoing issue with the pandemic. There were numerous changes the state implemented quickly, which was amazing. I've really never seen the state react so quickly. But they changed codes. They gave us the flexibility to provide services remotely, which were needed, incredibly helpful. So that was kind of a very unique situation. But you're right, just getting regular information out. So we have been meeting more and more with our providers. We're doing more electronic communication to the providers because it's always better to have it in writing. But yeah, very open to any suggestions on ways to get out, get the information in a usable, understandable format to the people in the community. I see our friends from the school district are on this call. I was at a parent advisory committee And I could tell from some of their questions too, that they were not aware of what's available through our system. So we're wrapping back around, trying to build those bridges, talk to the transition specialist at the schools. Yeah, so we're doing a lot more than ever, and it's still not enough. But anything we can do, any ideas or suggestions, we'd be very happy to entertain those. So thank you for those comments.
Do you think that it's, sorry, I just want to dig a little deeper into this so that we can get to those solutions. Do you think that it's a breakdown in the communication from kind of CMH to providers, or between providers and families and consumers?
Yes.
Got it. Okay.
Yeah, it's on all of those,
Okay.
and then even more. We had a fiscal intermediary tell families that the direct care wage was ending when it was actually increasing by 10 cents.
Oh no.
So families reached out to me, and they're like, what's going on? This is what we're hearing from our provider. And that I told them, I said, that's absolutely not true. It's actually increasing. We reached back out to the provider, then I still hear from families that they're hearing things. So some of it's between family members, some of it's between specific employees on the provider side.
Okay.
It's all over. And it's really difficult to, dissect and address individually. So really the answer is just more communication and more formats and forums, and keeping that door open for feedback so people can contact us directly. We did put you can now do like an instant message through our website. So you can type in an answer on the website as another option. So we're trying again to use technology as best as possible.
Excuse me, Representative Braybeck, can I just
Please.
say one more thing? Dave, that issue with that fiscal intermediary is still happening.
I heard yesterday. We're going back to them again.
Okay.
Yeah.
Okay. Yes. My caregivers who are here today just said the same thing. My caregiver said, I just got my paycheck and we just got this message.
It's now $2.35 an hour going forward. We've already implemented that even before the budget was approved. So we made sure there was no interruption at all.
Okay. That seems to be the only one. But it's such a good example of that issue that, there are a couple of fiscal intermediaries here in Macomb County that the majority of our families interact with and that are serviced by. And one fiscal intermediary, had no interruption in that pay, yet the other one does have an interruption, and it's, caused you can imagine the fear and the anxiety that employees are feeling, missing that $2.35 an hour. And then the frustration that, families are feeling that, they don't have the money to pay them out of their own pockets.
That's right.
And that fear that they're going to lose an employee because those employees can't pay their bills. So it's
That's helpful. Thanks, Shelley.
Mhm.
And that will be another thing that we get to. I'm sorry, I'm not trying to be rude. I'm also taking notes on everything that you all are saying. It's going to be another thing that we get to talk with in our talk about in our second question, which is, kind of things that are impacting workforce. And this will be one of those things. So, yeah. Karen, I saw you unmute yourself. We'd love to hear from you.
So I wanted to first thank Representative Stone and Braybeck for inviting me. I appreciate this opportunity. I tend to unmute myself mainly because I forget to unmute myself when I try to speak. So that's why I did that. But thank you so much for calling on me. I'm happy to answer the questions. So again, my name is Karen Wood. I'm the CEO of MyCare Health Center. We're a federally qualified health center with 3 locations in Macomb County. And, I'd like like to start off by complimenting Dave Pankatai, the CEO of Macomb County Community Mental Health, for his collaboration and partnership. He's really made an effort to work with MyCare to try and really help provide services to the community, to make sure that we're coordinating our efforts and to just do a better job of taking people during these strange times. So, it's really obvious that behavioral health care needs have increased significantly with this pandemic. So over the last 19 months, everyone has been stretched very thin, and agility has been very key. I wanted to talk a little bit about the state more so than Macomb County, if that's okay. And one of the issues that people encounter is finding out how to access services going from one PIHP to another. Things are not streamlined workflows. There's a lot of confusion regarding who qualifies for the specialty behavioral health benefit, who doesn't, how to access services for both behavioral health and SUD treatment. A big barrier that I see to accessing care is that things vary depending on where you're trying to get services.
That's really helpful, Karen. Thank you for that. And I think we see that in a couple different dimensions. We see that in terms of, the front doors of, where's the front door for folks so that they can, they know where to go to get the services. But also I feel like across counties, there are some issues again, and we'll be able to talk about this, about for workforce, right? Like the trainings can be different. Folks have to go to, from one county to another. Again, to your point, learning the new system, all of those kinds of things. And want to make sure, again, we're trying to be really attentive to all the acronyms. And so for folks, a PIHP is a prepaid inpatient health plan. And if you kind of think about different levels of our system, we have, DHHS, which, gets money in from the federal government, federal money. And then we have 10 PIHPs, which are kind of regional entities. And then we have 46 CMHs, or community mental health organization. Well, you can be lots of different things, right, Dave? Or 3. You can organize that in 3 different ways. So the CMHs are underneath the 10 PIHPs. And so that's kind of the layering of the mental health services. And really the other part is that the substance use usually comes out of the PIHP. They can partner with the CMHs, but that's kind of the organizing agency for the SUD, for the substance use disorder services. I don't know, Dave, Karen, did I do an okay job on that? What did I miss?
You did great. I was wondering if I could have Brooke on all of my Zoom meetings, just interpreting for me, kind of.
She's amazing.
Macomb County is both, and the PIHPs get the Medicaid dollars from the state. The CMHSPs get the general fund dollars to coordinate those public safety net services and stuff. But yeah, that's our system. And I know PIHP is a horrible term, but that's how we're set up.
Yeah. So love to hear from other folks if they want. Linda, Sabrina, either of you want to answer? Yeah, please, Sabrina.
Hi, thank you. This kind of just piggybacks on what Shelley was saying about the communication issues. And my experience is a little bit less recent. My daughter, we used Easter seals to get her ABA therapy. That was like 2017 and 2018, so it's not quite as recent. But I have a pretty specific example of something that I think kind of backs up what Shelley was saying, and it's that lack of communication. And I remember struggling with our advocates through Easter seals. we would be signed up with someone. We would have a name and a number and a connect there, and we would know who we were talking to when we had appointments, when we had to go in for assessments and things like that. And that would change with no notice. We would get no phone call, no email, nothing. There was one specific time that we went in for an appointment for an update, and we didn't have anybody assigned to us. We had a person who had left, had just dropped her caseload on the desk and walked out. And they put us in the waiting room for like an extra 30 minutes and basically found somebody to grab her file and then take us back into the room and discuss what was going on with her. So we went, I think it was about a year. We went through 4 different advocates in that 1 year, which is hard on, it's hard on parents, but it's especially hard on a child who has a really difficult time when that's another stranger and another new voice. My daughter is autistic and she's legally blind. So another new voice, another new person, it's very hard for kiddos like that. But I also do want to be fair and say that our 4th advocate, he stuck and he was really good and we really did well with him. And he came to IEP meetings with me and he was very helpful. So there's 2 sides to it. But yeah, that lack of communication when I show up for an appointment and I don't even know that I'm going to see the person I thought I was going to see, or if anybody will be there ready to see us, that's stressful.
And the behind that is staff turnover. So yeah, you're right. That's another historic problem in our system. It's widespread, but pretty high there at the supports coordinator, case manager level.
Yeah, thank you, Sabrina.
Rep Braybrooke, I saw that Karen Peck had raised her hand earlier.
So one of the things that we're going to try to do is we're going to try and have all the folks on the panel answer all the questions. And I'm going to keep, so Karen, you are first on our list. You'll be first on our list. Because one of the things that, these are amazing conversations and I love them. And I could talk about mental health stuff, forever. But I also want to be respectful of folks' time. So we're trying to do this one piece and then move to the other piece. Thank you for that heads up, Dave. I appreciate it. Linda, please.
I was trying to go next, but my internet was going in and out. So I've moved and it's much better. Is it fine? One thing that I think that we do best is because the acronym CMH, the C is for community, and we are in the community and we are on the ground. And we're, just an example is we meet twice a month at the county building, and we have opportunity for public comments beforehand. And in September, maybe the last meeting in August and the first meeting in September, parents came before us telling us that they were having trouble getting a way to pay for their children to a provider that they thought was really what their child needed, because they weren't contracting with us. And by our very next meeting, the local CMH, because we're here and on the ground, had responded and had taken steps to issue a request for proposal. So that's not going to happen with a big corporation that's not even, in Macomb County. In terms of customer service in Macomb County, we've just initiated a big customer service response, and our deputy reported to me that the abandonment rate for July, August, and September, that means people who hang up on the call because they've stayed on too long waiting to talk to a customer service rep, which happens. Have you ever tried to call Delta Airlines lately? Is down to 5%. And we handle 4,500 average calls per month. So, and these are people who live here, work here, and when you do get them, they know what office you're talking about, and they probably know the staff person that you're talking about, and they know the provider that you go to. So to me, that's a big difference that we're here.
Yeah, those local partnerships that happen because of the relationships that have developed over years. And then, if often, right, when clients and their families need extra support, those relationships are already in place to make those calls, to be like, as you said, boots on the ground in the community, like that's already there.
Right.
Yeah. Thanks, Linda. Well, we're going to move to something that many of you touched on, which is workforce. And it's one of the big things that keeps coming up in lots of different ways in our stops. What do you think can be done? Two main things, both in terms of recruitment of mental health care providers, because we're seeing shortages at all different levels. And what do you think can be done about recruitment? And then what do you think can be done about retention? Like actually keeping folks here in Michigan or keeping folks, in the CMH system, rather than, some of the times young therapists can come out of school and get a lot of training at CMHs and then move on. And so what are some of the things that we can do in both of those areas? And what do you think are some of the biggest issues? Shelley touched on this. What are some of the biggest issues that our workers face? Is it, that pay? And we're, thank goodness, finally able to get the $235 additional for the direct care workers. And I just want to add, really, for my little soapbox on this, like that was needed before the pandemic. That wasn't, and so we were finally able to get it during the pandemic, but that was needed well before then. And so, there's still more advocacy to do around that. But, would love to hear folks' ideas around recruitment, retention, workforce issues in general.
I guess I'll field that one. I've been involved in numerous statewide meetings with folks from the department about this issue. And you're right, we had a staffing crisis shortage before the pandemic that turned into a crisis when the pandemic hit us. And as this drags out, it just continues to erode our workforce. So it's really at a critical crisis stage right now, and that's our message to folks at the state level. We shared, we did like a round robin across the state about ideas and suggestions. We were listened to. We haven't received any feedback yet on those, but some of the things that were discussed were making the direct support professional more of a career path, increasing the public perception of that role, and really recognizing how important it is to everybody in our community. We are having some talks with Macomb Community College, and the state tuition reimbursement was one of the recommendations. Macomb Community College actually has a really good foundation now. I learned a lot just in the first meeting. They have like a pre-social work track. So I think if we can design this appropriately, folks coming out of high school who are not on a college prep course, or who are, using myself as an example, I worked my way through my undergrad in psychology as a direct care worker. So people are interested in special education, psychology, social work, the behavior techs, job classification and stuff under the autism benefit. It's a great learning opportunity. So I think we need to recognize that, elevate the perception. Here, we also have a meeting. Our follow-up meeting is tomorrow morning. We're planning to host a countywide job fair that initially was focused only on the direct support professionals, but we're opening that up to everybody, all professionals, including those direct support. We're working with the Macomb County Provider Alliance and then some of our other providers as well. And hopefully working with Macomb County as a whole to help get that word out. So like when I met with the Provider Alliance, pretty much all of those providers are competing for all of the same staff at all the same time, and they're all spending their money and resources to try to recruit those folks. So I thought we could help them a little bit. We'll see how this goes, and if it works well, we will definitely do it again. But that's one of the ways we're trying to help the providers here in Macomb County and to get some more options. We are also issuing more RFPs to attract more providers, more staffing and home providers, more outpatient clinic providers. And I think Linda touched on it too. We opened up one for the ABA or the autism services providers as well. So we're trying to grow and expand to meet the needs of the community as best as possible. But that staffing shortage is prevalent and critical.
Yeah. Anybody else, please, again, recruiting folks, retaining them here with the staffing shortages.
Well, I think the idea for them to see it more of a career and for them to be recognized for the important role they play and the importance they, are the important part they play in the lives of the people that they serve. Not to hinder them with a big credentialing or licensing requirement, but to have training classes so they have confidence in what they do and recognition for it as a career would be helpful.
Yeah, that's one of the things that we've been talking about is what's that balance between, the career path, maybe that means us, Rep Stone, Rep Hertel, working with Laura, right? Like to try and figure out what that could look like. But then we don't want it to tip that scale and become, just another requirement that makes people kind of throw their hands up and becomes another barrier, and so trying to figure out what that is. And I know, and Dave, maybe this is who you were talking about. Is it, I don't think I know, I can't remember if I'm gonna get the name right. Impact, is that who's doing that work around the career path in part?
That's not ringing a bell, I'm sorry.
Okay.
But
and there is a group that is doing some of that work for us. And so I've been kind of anxiously waiting, for what is going to come out of their work to see what that can all look like. But I liked the idea that you just were talking about the job fair. Where are you doing that?
I think we're doing it mostly virtual. And we're allowing people to contact us through pretty much any means possible. They could send it snail mail, they could send us a text that they were interested, and then we could follow up with a phone call. But we might have an in-person component to that as well. But we're planning on it being very broad and making it as easy as possible for people to let us know that they're interested so that we can follow up.
Okay. Thank you. That's helpful. Shelley.
Okay. So I think that those are great ideas that Dave has. And, I was fortunate to sit in one of the meetings at the ISD a couple of weeks ago, and I heard all those great things. And so I think that's a really great start. And it's something that hasn't been done before. And I challenge CMH and the community to take a step even further and going to high schools and getting the kids when they're just going into college is great, but go even younger. We have elementary schools that have career days. We have middle schools that have medical clubs. My 12-year-old twins go to Heritage Junior High. They have a medical club. They are looking for things like this. They're inspiring young people to go into these fields much earlier than high school and college. So, light that fire early, and like Dave did say, make it an exciting thing and try to remove that stigma, because it is, there is a stigma with it. It is not an easy job being a caregiver. My daughter is 19. She requires 100% assistance with all of her ADLs. She's nonverbal. She has a lot of medical problems. So, I'm fortunate that right now I have two wonderful caregivers, which I will lose them both within the year, because one is becoming a PT and one is becoming a nurse. But we fostered that love of learning and education, and we've been able to keep them. We're a rarity in that world because Dave, and all the other parents on here can attest to keeping caregivers is very hard. Direct care staff, whether you're self-determined and you hire your own staff or you go through an agency, it's impossible. Like it was stated, the staffing crisis is of epic proportions at this point. We were having a major staffing crisis pre-COVID, and now, like Dave said, it has now gone all the way up, and now it's hit support coordinators and all of his staff. So now it's all over the place. So I think his ideas are great, and I think that's a great start for us and for families. That the biggest issue that we hear is that they are just not allowed to pay their staff enough money. And when you are asking a staff member to come into your home or to work with your loved one and do very intimate jobs like changing diapers, bathing, feeding, communicating with them, taking them out in the community, and helping them be a productive member of society, that is a very intimate position. And it's it requires that caregiver to give their whole self and 100% of themselves. And when you pay them less than what people make in fast food industries, you can't expect them to stay around. You just can't. And the turnover rate for our families and our consumers is too much, and it's too much of a risk when you're dealing with families and consumers who have nonverbal consumers, and who they're just they need that good care. So,
well, and Shelley, I think you hit on a couple really important points, is that we have to try and solve this and at least make a big dent in solving this, because of the turmoil that it throws families into. And that's something that I know that I worry about all the time, is, again, with that high turnover. And it's, as you were saying, it can be a really challenging and rewarding, job. But those relationships get built, connections get made, right? It's a unique kind of world, that direct care workers are in. And your idea about going into high schools is spot on. That's another theme that's coming up. Like, how do we have contact, with younger kids? And one of the things that, and Rep Stone knows this from working in schools. We right now, the state of Michigan, we are ranked second from the bottom in terms of how many guidance counselors we have per student. So right now we have one guidance counselor per 691 students. And so to get that message about those, the things that you were exactly talking about, Shelley, like, is hugely problematic right now. And so we have a bill now that's going to try to address some of it and improve the ratio. It's not nearly where it should be. It's a step in a better direction than 691. But I agree with you. Like, if we can start earlier, but we need to have the staffing there to be able to get this word out to the young students, to those high school students, as they're making those choices, Dave, to go to like the program that you're working with, Macomb Community College. We have to be able to get those messages out there. So I completely agree. Thanks, Shelley. Who else wants to talk about this? Linda.
This is just anecdotal, but this week I heard the chair of the board of Network 180 say that when they increased the wages to by the 235, they had the same situation, really. It didn't improve their hiring. But they then added $2 recently, and it's made I found that just $2 would do it, but he said it's made all the difference in the world in terms of recruiting.
And you're right, Linda. I mean, and that's one of the other things that keeps coming up too, is, and I'd be curious to just hear from all of you about this is, and Shelley, you were touching on this too, the reimbursement rates and the issues around reimbursement rates. And then the impact that has on, again, whether you're doing self-determination or through an agency, the ability to be able to get workers in, and the potential lack of understanding about what goes into service provision when rates are set. And so I think that it's, I'd love to hear your perspective. I wonder about the impact of that on this issue, this workforce issue as well.
I heard those same comments, that when you get closer to $17 or $18 an hour, then people are actually responding to their ad. Yeah. How many of them actually ended up, working and, being hired and working? I didn't hear. That causes a ripple effect, though. Once you start getting to those numbers, then you're getting close to what some of the other professional staff are making. So it, just grows.
Compression issues.
Yeah, it extrapolates out from
right.
there.
Yeah.
But everything you read about why people stay and why people leave, money is usually not, in the top 3 to 5 reasons. And so I don't think money's the only answer to this problem. I think that the recognition, the support for those staff, sometimes there's, I wrote some answers to some of these questions, and a lot of these issues they're a double-edged sword. So on one hand, from the federal level on down, there's been discussion of self-determination. So the ideal is that I would be living on my own with a paid support staff who work for me, who I selected, who I had, a lot of control over when they worked and what they did and all these other things. It's wonderful. I'm a big fan of that model. The issue is then it's decentralized. So now you have a bunch of people working in small, with a single person, and then it's harder to connect with that person. It's harder for that person to feel supported in the workforce, or to be part of a larger group, or to be recognized. So it's, like I said, it's a double-edged sword. We do want people to be out in the communities, part of their own communities, to be as independent as possible. But then you have this decentralized system, and it's hard to, a lot of us with this pandemic, you can see I'm working from home right now. There's a lot of perks and benefits to being in the office, being around coworkers. You have that, the social aspect, and it's easier to give immediate feedback, reinforcement to others when you're right there. It's a lot more difficult when it's decentralized like that too. So yeah, it's a tough balance.
Yeah, that's a great point, Dave. That's really interesting. That is very interesting. Thank you for that. Who else, before we move to the next question, I just want to make sure that everyone who wanted to speak again about workforce was able to lend their voice to that. Did we miss anybody? Okay. So let's move to the next question, which is about administrative and regulatory aspects of this work, and all of those compliance issues that are part of this on a daily basis. And what do you think, what opportunities are there around this part of the work that could be improved, or like what areas might be duplicative, or again, what opportunities do we have around this kind of aspect of the work? Anyone can go for it. I know that you all know that there's a lot of administrative issues and and things that you all have to do both federally and statewide. And we want to hear, again, there's not a lot we can do about the federal part, but the state part, we want to hear from you all about what feels burdensome. Please, Dave.
Well, from the board perspective, the mental health code is really our basic.
Yes, that's right.
Guideline. And I really, hope that people are very careful not to alter the mental health code to meet this new system they want to go to.
Not to sound like a broken record, but to use the double-edged sword again. So Michigan has some of the most flexible, creative Medicaid waivers in the entire nation. That's a huge benefit and a perk for everybody here. Each of those comes with its own set of the strings that are attached to each of those waivers. Our PHP contract now is over 750 pages long. You're dealing with federal dollars. There's a lot of accountability that goes along with that about how you're spending it, how it's being used, and you need the audit trails, you need quality audits to show all of that. So now, if I'm a provider and I'm working with a bunch of different regions or PHPs or CMHs, another benefit, which was touched on earlier, is at the county level, we can get creative and flexible about how to best use those funds for our county. And that's a strength. That's a huge benefit of our system. But now Macomb County is going to be different than Oakland and Wayne and St. Clair because of that, county flavor that we're doing about what's important to us right now. How are we spending our money in that area? So, you have to kind of be careful about those unintended consequences. If everything was cookie cutter, then some of the programs and services that we are doing specific to Macomb right now would be gone, would be completely eliminated without a second thought or any consideration for how much that was benefiting our county. But then you could more easily move between counties and regions and get the same type of thing. So, like I said, sometimes you just have to be careful what you ask for because it could end up looking different than you really wanted it to be.
Yeah, that's helpful. Do you think, this is Dave for you, Karen for you too, like, do you think that, the number of audits, are there any opportunities there that, that to streamline that process?
So on that topic again, we do share information across the PIHP level.
That's good.
So
okay.
I know my counterparts very well.
Yeah.
We meet monthly at least. We do have a training reciprocity agreement in place. We have a SharePoint file, Teams file now. So I can submit our training and it'll be reviewed. And if it meets those standards, it goes into that centralized database. And then if you've had that training, you could go anywhere else in the state and you don't have to repeat that. We have quality monitoring agreements in place for the local community psychiatric hospitals. So Macomb County is responsible for auditing, reviewing all of the psychiatric hospitals in our county. That way you don't have, 10 PHPs or 46 CMHs coming to audit and having to travel across the entire state to come look at one of our hospitals. So we do share information as much as possible. We do work in a collaborative fashion as much as possible. By and large, we get along really well.
Dave, that the audits that you do for the state hospitals, do you then proactively share that with the other PIHPs?
Yeah,
and
it
the
goes
CMHs?
into a folder that we'll have access to. So
Not just within your region.
No, statewide.
That's cool.
We're all members of it.
That's cool.
We fund that service together. We share that information.
Okay.
We get email updates. So I know that when Pine Rest on the west side of the state was audited, we get access to that documentation.
Interesting. You said that that's through just teams, like is the association doing that? Who's organizing that?
It's another acronym. It's MCHE. It's the Michigan Consortium on Healthcare Excellence, which is 9 of the 10 PHPs working together.
Michigan Consortium on Healthcare Excellence?
Yeah, MCHE.
I don't know this one. I'm excited to learn more. Thank you. So that sharing of information is so much, that part's really helpful then. Okay. That's great.
And also for parity through that group, we all are using, most of us are using a software system to do the hospital reviews so that they're done consistently statewide.
Okay, that's helpful. Thank you.
So if I could speak a little bit about physical health and behavioral health integration. So integrating primary care and behavioral health is a very effective model of care because it looks at the whole person and it facilitates care coordination. So My Care is a federally qualified health center, has partnered with Macomb Community Mental Health for a program, and I'm going to spell it out because I don't want to use any more acronyms. So it's called a Certified Community Behavioral Health Clinic, or CCBHC for short. And Macomb County approached My Care to be their physical health partner. And it's really a great marriage of different entities to take care of that whole person, including data sharing. So the flow of information is flowing both ways so that we're able to take care of the whole person. Typically, I know I'm preaching to the choir, but typically behavioral health and physical health operated in silos. So this type of collaboration breaks down those silos, and it actually really helps that patient get better care because everybody's talking and everyone has access to the different, we're not repeating labs if the other person did it, right? We're able to share labs. We're able to know what diagnoses these patients have because we're able to share this data. And so it's a pretty effective model of care, and we're super excited to expand that program. Another pilot program that we're involved with community mental health with is the opioid health home through the Macomb County Office of Substance Abuse. See, I'm getting much better. And that allows My Care to get some funding for some services that we were providing previously that we were not able to get reimbursement for. So for substance use disorder treatment, our physician is able to provide medication-assisted treatment. We have a peer recovery coach that takes care of that patient. We have a therapist that sees that patient. All of this is all done under one roof, where previously a patient would go here for therapy, there for their peer, go there to see their doctor, go there to see their psychiatrist. Everything's kind of done under one roof. And then the information flow is there as well, because we're actually doing some reporting in community mental health health record called Focus, or behavioral health record called Focus. So, they're auditing us. MACOSA is auditing our treatment plans and our service to these clients. So I think it's a step in the right direction. It's not being done everywhere. It's only being done in a couple different counties, but further integration makes a heck of a lot of sense, so that, we're treating that whole person and not continuing to just have this person treat behavioral health and this person treat physical health. So I definitely wanted to mention that, and hopefully moving forward, these wonderful programs can be expanded to better care for people across the state, because they just make a heck of a lot of sense. I know Dave was looking at a data analytics platform that we have, and so that we could further facilitate the flow of information, because, previously we were doing a heck of a lot of manual data evaluation, where now these data analytics platforms make it very easy. What I can do in 5 minutes used to take me a couple hours. So, we can run a report on a psychiatric diagnosis and medication, and then make sure that we're, have maybe some treatment or planning sessions to in-service our staff to make sure that they know the best way to treat this population, or whatever that looks like. It might look different, but a lot of real strides have been made with data analytics, and we're trying very, very hard to work smart versus work hard, and increase these collaborations. Oh, thank you, Dave.
A round of applause from Dave. Yeah.
Karen, you did a great job. Yeah, MyCare is just a wonderful partner. We were collated previously. Macomb is very unique right now statewide. So we got the federal expansion grant to be a CCBHC last year. We're actually wrapping up our second year in April of 22. And October 1st, to wrap back around to access issues and stuff, we became part of the state of Michigan's demonstration project to be a CCBHC. So we actually have 2 of those programs running concurrently. We are also have the opioid health home, and we're on my HealthLink area, which is again providing the care coordination for people who have Medicare and Medicaid. And we work with the Medicaid health plans to do that. So we are doing a lot of integrated healthcare. We are focusing a lot on the data aspects of that Karen spoke to so well. We have admission, discharge, transfer. We get information from the physical healthcare side, from the healthcare systems, when somebody's admitted or discharged from an emergency room or from a medical hospital. We know when they go in for a psychiatric hospital admission, because that's under our umbrella. But yeah, we've made great strides in that area. And we think this is the model that should be continued and supported going forward. There's no need to redesign the system at a higher level when it's already working and off to a great start. Our first year report that we did to SAMHSA at the federal level, every outcome, every health indicator had improved for the people in our CCBHC project. So,
well, and one of the things about CCBHCs that we're seeing, I know at some of the sites, we have a site here in Washtenaw as well. And one of the things that we're also seeing is increased access, so one of those issues that we were talking about. So increased access and decreased hospitalization. right? Which is one of the measures that we want to see, because we know that, when folks get to the level of acuity, that it can be like, there can be a million things that happen that are detrimental. And so if we can help folks before that, that is fantastic. But the CCBHCs, I feel like, are also so much more than integration. I mean, Dave, you answered a question earlier, about students and insurance, and with the CCBHC, like it allows the scope of practice, so the folks who you can actually serve to be wider.
Yeah,
and
I should have touched on that.
Yeah.
We have traditionally, we have been supporting people with serious mental illness or children with serious emotional disturbance. With this new project now that started October 1st, we're able to help and support people in the mild to moderate category. So now there's really not as much screening and assessment. We're not trying to rule people out, screen people out of our system. It's come on in, let's see how we can help you. Third-party payers will be able to bill directly. Technically, you don't even have to be a resident of Macomb County, which was traditionally a requirement under the straight Medicaid funding. You could have generalized anxiety, some mild depression symptoms, and we'll be able to help and support you.
And I don't think that the relationship in Macomb County between FQs and CMHs or PHPs is that all that common. I know there's some integration, but this level of integration is, from what I'm hearing, somewhat uncommon. And it seems to just make a lot of sense to me. So.
Yeah, that's helpful.
Thank you, Karen.
Yeah, I do want to, I want to talk more about that integration piece, but I wanted to circle back really quickly. And Sabrina and Shelley, I wanted to get your inputs as secondary consumers about administrative aspects of CMH, and would just like to hear from both of you about, was there anything that was burdensome for you trying to get your children access to services, and just trying to understand what opportunities we might have there too?
I can speak to that.
Yeah,
So a couple of things. As far as burdensome goes, one of the things that my caregivers and that we hear from some caregivers is that sometimes some of the training that they are asked to do isn't always, they don't always feel it's necessary for the families with whom they work. So, and I see why they have to offer all of that, because some of our agencies, work with different nationalities and those who speak or don't speak English and things like that. So although there is a wide variety of training that is available and is required, I don't know that it is always all required, and I don't know how that should be addressed on the CMH side. But what I worry about with that is if you're putting direct care workers through this training that's not necessary, they are then billing, because they get paid sometimes to do those training hours. So they're able to get, reimbursement for doing some of those trainings. So now here we are, they're turning in a reimbursement form to, be reimbursed for doing that training. And if it's not a necessary training, then we're spending unnecessary funds. So maybe that's a way that can streamline some of that, and hitting the important ones, recipient rights and bloodborne pathogens, first aid and CPR. Those are all, very important, but maybe some of the other trainings, that could be looked at and decided upon whether or not that is something that's necessary. I do realize a lot of that probably has to do with the mental health code. So, but again, I don't know how that would transcend, down to or up to CMH, but it's just something I think that could be looked at. And the other thing, and I think this has changed now, Dave, when I sat in on that meeting with you, you mentioned that the access line and that first point of contact has changed. And I think that's a really great thing, because prior to that change and how a family would request services, a commonality was that a family would call this access center, and you would say, parents would call in desperation when they hadn't slept for 4 days and their children had been up for 5 days and maybe had really bad behavioral outbursts or significant, mental health issues or medical issues. And they would call in desperation and say, I need help. I don't know what to do. I need help. And at that time, the answer was always, well, what would you like? What do you need? And you were never told what CMH offered. It was, you had to know what to ask for. Now that has changed over the years with, the updates on the website. But I think that still is something that can be worked on, is that continue your outreach to communities and saying, this is what's available under these 3 or 4 umbrellas. These are the services that you can call and ask for or inquire about. Because I think that's important, that families, consumers, and our community know what is available, so that you can continue that community outreach. That is, like Linda said, one of the great things about Macomb County CMH is that you guys are in the thick of it. You are on the ground, you are in the community. So continue that outreach and continue, shouting from the rooftops what is available for your community.
Thanks, Shelley. That's really helpful. Sabrina.
Yes, I agree definitely with making those things known to people when they're calling or trying to get services, because a lot of what I went through, and again, this was a while back and it's changed, thankfully, was digging and calling several numbers, some of which were disconnected. People couldn't, I couldn't get a hold of anyone. And then waiting but that's changed. Don't, it's okay. Don't hide, Dave. It's better now. And also, having to wait you call the ped psych, and you have to wait for the evaluation to be sent to me. And I was working at the time, so can you fax it to me at my job? And then I have to take another break from my job to go fax it to this other person. So the idea of it all just being connected, I don't have to stress out and do all of that, is very exciting.
Yeah, I think that part of what you're talking about, Sabrina, is also part of the improved communication with the CCBHC model, is that, of course, like with consent, like, there's more sharing of information so that decisions can be made better and quicker.
And it makes such a difference. It does.
Yeah, that's really helpful. Thank you.
Macomb too, we're working with a national consulting group to improve that experience at the front door even more.
Yeah.
So that parents don't have to tell their story more than once.
Yeah.
To really use technology to its fullest extent. So they're currently in place and working with us. We're expanding our customer service to 7 days a week. We do have mobile crisis services. And we have a mobile health unit now too, and we're doing a community needs assessment to kind of target the areas around the county where they might have a harder time accessing our services, or they might not know as much about what's available through our services as possible. So we have a lot of efforts underway to continue to expand out into our network and connect better.
Are you able to do those things, the last couple of things you were talking about in terms of expansion of services, because of the CCBHCs?
In part, yeah.
Okay.
CCBHC really stresses the community connections
Right.
to the other. We had to get memorandums of understanding
Okay.
with other community agencies.
Okay.
And that was really interesting. Really good experience doing that, really good feedback. We should have always been doing that, though, to be honest with you. This just helped move us along. There's a real emphasis on homeless and veteran services, and then our connections to the schools. And so we have a lot more planned, and a lot more to do. We're not sitting back and resting at this point at all. So.
Yeah, that's really helpful. And I know that we've been talking about, and Karen, thank you for kicking off that part of our conversation here about that integration. I'd like to, open it up to Linda or Sabrina or Shelley, if any of you want to talk about that integration piece. We'd love to hear from you before we move to the next question. Can we just, is it all right?
Yes.
Okay. So,
yeah.
For our last two questions, and then we'll be able to hear from other folks who are with us this evening. We're going to talk about telehealth, which we mentioned earlier, but also the first question I'd like to focus on is, what opportunities do you think that we have in terms of improving prevention and early intervention? And we can, even think about it now in the context of the CCBHC and what now is available in terms of services around this. But, would love to hear from all of you, again, both from the agency perspective and parent perspective, about what opportunities and things we may want to focus on.
Well, I think the mild to moderate is a big thing, that we are going to reach people before they get in the crisis and the hospitals and the homelessness, and so that's a great preventative thing, and it's a wonderful thing that we're able to do it under CCBHC.
Great point, Linda. Thank you.
I think we're seeing this now nationally, where mental health is health, and reducing the stigma. I saw it so clearly with the autism services. It used to be a horrible stigma if your child was autistic. And now you see the ribbons on the cars and everything else. And it's really done a complete 180 with that. Now with parity and everything else, with your doctors giving you a list of asking you those PHQ-9 questions, which are the screening questions for depression. Mental health needs to become normalized and a regular part of your health, just like going for an annual checkup, going to your dentist for the preventative cleanings, getting your immunization shots for your children. We need to be openly talking about it and making sure that those services are readily available and easy to understand and access when somebody's in need of those. Because using myself as an example, I'm going to look for every opportunity to not go, oh, I'm fine, I'll walk it off, I don't need to go to the doctor. But it needs to be there when the person needs it. And that's definitely on the substance use side. When somebody's having that problem and they get to that point where they're like, I need help, you've got about 5 minutes to get that help to that person, or they're going to go, oh, well, I tried, I'll go back and do what I had been doing. So it's increasing, again, this common theme, increasing the awareness of what's available, but then making sure that it's there, when you call, that somebody's answering the phone, that they're friendly, that they're directing you to appropriately, and you're getting the help that you need. That's, my wish for the entire system, I guess.
That's great. Thank you.
So I should If I may, I should maybe comment on some of the behavioral health work that's being done in the primary care setting. So we are seeing a lot of mild to moderate patients. Our physicians are prescribing medications. We have been screening everyone 12 and older with a PHQ-9 for years, and it is required that if they fail that PHQ-9, that a referral and education is provided. So there's a lot of this work being done in primary care FQHC offices. I believe the Michigan Department of Health and Human Services recently developed a new behavioral health fee schedule. So it's going to be really important that that fee schedule is appropriate for the real costs that are incurred by providing behavioral health, and that adequate provider networks are developed. We currently have a lot of issues getting paid for the work that we're doing. And a lot of that is related to some of the health plans actually contract out with behavioral health providers, that so we can't see that patient. They have like a different group that they contract with. So the patient might see us, but we can't treat them for behavioral health. We're running into a lot of issues with credentialing providers taking a very, very long time. It's hard to adjudicate the billing and to actually get paid. So just streamlining some of the health plan issues that we encounter would really help us serve more people, because the more time that we spend with administrative tasks, the less time we have, the less money we have to take care of people. So, and it's really a burden on providers, not just us, but across the state.
That's helpful, Karen. Thank you.
Mhm.
Sabrina or Shelley?
I'd like to just point out, make sure that we know or understand that by bringing the mild to moderate, we're also impacting the substance use disorder numbers too. It's that's why people are self-medicating often and gets and leads to the higher caseloads too.
Yeah, that's helpful. Yeah, thank you. Well, I'll lead us to our last question that's been touched on before we open it up to be able to talk with folks more, which is telehealth. So telehealth was around before the pandemic. We saw it used in a much more prolific way during the pandemic. What's telehealth? What have folks' experiences been like with telehealth? What do you think about the use of it, and how does it work or not work for your community? Shelley, please.
Okay, so telehealth for us has worked well, and specifically, I'll just give you a quick scenario of what we went through with the pandemic. My daughter went from the children's waiver and was 17 and turned 18 the week after the pandemic hit and the whole world shut down. So we were very scared because we were working on guardianship, and it was a very scary time. But the telehealth portion of that was helpful for us, not only on the telehealth side, but as far as community mental health goes, our support coordinator was able to stay in constant contact with us. And so when I was very worried about whether or not my medically fragile child was going to have to go in the hospital, and who is nonverbal, and how would I get in there when the whole hospital is shut down, my support coordinator was there for me that whole time. And I will tell you that she is probably the one reason why I didn't require mental health interventions at that time. So I think that one of the greatest things that has come out of this pandemic is telehealth, and the normalization of it, and the everyday use of it. And I think it is definitely something that, you should continue doing in every aspect you can. Because even if a person doesn't have access to a computer, I would have to say 100% of them have access to a telephone. So if they cannot log on to a visual telehealth appointment, they most certainly can somehow gain access to a phone. My mom is one of those people. She cannot, she has a computer, but it's just, she's 82 and it's not going to work out. So, but she is able to do her, some of her health visits over the phone, and that has been very helpful. So I definitely think that's something that it doesn't work for everything, but I definitely think that it is something that you should continue and do what you can to keep it going.
Thanks, Shelley. That's helpful. Who else would like to talk about this? Telehealth.
Shelley, you covered that really, really well. Thank you. We were very lucky. We were able to transition to the telehealth services pretty much over a weekend. We did benefit from some of the federal CARES Act dollars that came down to Macomb County to upgrade our software and our hardware. But all of our staff have laptops, tablets, cell phones. It was a lifesaver, continues to be a lifesaver in this environment. It did allow us to, psychiatrists, when you talk staffing shortages, there is a shortage of psychiatrists, especially a board certified child psychiatrist. Now with telepsychiatry, you could contract with a psychiatrist from Hawaii, and they could provide those services. The phone services, I agree completely, Shelley, are still needed. There are some services that have to be done in person. Of course, the staffing supports that we discussed earlier, injections. We have a number of people who are doing really well in the community as long as they get the monthly injection. So we continue to provide those services. We've recently upgraded our fleet to help go out and access those folks in need. There's a federal program that will help you get a free phone under certain situations. I can pull that information up as well and share it. But so we encourage those things. Linda connected us to the library system as well, which is it's a community hub. It's accessible, and they have computer systems. They might not be a great place for telehealth, but you can definitely find resources to better connect you to services as well. So our connection to the libraries the libraries in Macomb County, the Library Collaborative, has been a very good connection. We've provided trainings and seminars virtually to that group as well.
I love that idea. That's a great idea, Linda. Thank you.
So I love telehealth. I love telehealth. Previously, we could not bill for telehealth. I don't know if everyone understands that. And we too were able to benefit from CARES money. We were able to implement a telehealth platform within 48 hours when Governor Whitmer's executive order that mandated that only emergency care could be provided. So we've used it extensively over the last 19 months across all of our service lines, except for our dental centers. And then, it's been really helpful to help patients access care. There are some limitations with telehealth. As far as, like Dave mentioned, injections, we've had patients really accept it well, and then they don't want to come in. So they might need to be physically examined, get immunizations, have some lab work done. So we have to really evaluate every patient on a case-by-case basis and really think, when was the last time you were in and what needs to happen next time? So there are some limitations, such as nonverbal communication, especially for therapy and psychiatry. Body language can really tell a clinician a lot about what's going on with the patient. So that is a limitation. And then, like Shelley mentioned, my father could not set up telehealth either. So I feel your pain there, Shelley. And then especially in rural communities, not everybody has access to Wi-Fi. We actually have outfitted all of our clinics with parking lot Wi-Fi. So if the fear was that they had COVID, that they could pull into our parking lot and actually have a telehealth visit. So I hope telehealth never goes away. I think it's been really a blessing, and I hope it continues. So, please pass that along. Please encourage legislation that continues that access for patients. So thank you.
That's great. Thank you so much. Sabrina, did you want to add to this, please?
Just completely supporting what they've said, and Ms. Stone beat me to it in the chat that it will help with some of the transportation barriers as well. We have a lot on our plates in a day. I mean, sometimes it's not easy to schedule that, plan around that. If you have the kiddo, get the kiddo in the car and ready to go. Sometimes it's easier. And I love it. I'll use it for anything I can where I don't have to physically go into the building. I'm one of those people who would, yes, put me on the computer.
That's great. Thank you. This has been incredibly helpful. I feel like, again, we were talking earlier, Rep Stone, another gold star for Macomb County. This is the first that I've heard about, like, the libraries, and really utilizing those as hubs and partners. So that's awesome. Like, I'm super excited to hear about that and talk about that with other folks. So thank you to all of you who are panelists today. Thank you so much for your insights and giving of your time tonight. And we want to also hear from folks who have joined us. Karen, I know, did Karen leave us? She might have. So Karen, I know Karen Peck said she wanted to speak, but if there's anybody else who is here with us this evening, please raise your hand, and we would love to be able to. Oh, I see the ISDs. Please. Hi.
Still muted, Justin.
I only see Mark's hand unless I'm missing one.
Justin's trying to unmute from the.
Okay, Laurie, I have you on the list.
There we go. Hi, my name is Mike DeValle. I'm County Superintendent, Representative Bearbeck. Glad
nice
you're
to meet you.
Representative Stone and also Representative Hertel. A couple things on the shortage. Everyone's got shortages. So my view is on this, one, it comes down to money. And I would tell Dave, if you want to have a recruiting fair at our building, I think you do better in person. Henry Ford Hospitals had 2 recruiting fairs here, 2 days. They ran from 12 to 6 or 7 o'clock at night. You can use our building on weekends, no charge. But I think you got to hustle to have people come in face to face and try to sell them on your program. I don't know if you're going to sell anybody on the internet or on Zoom. You got to have folks where you can talk to and draw them in. So that's the one thing I would say. And with regard to money, I would ask Senator Shirkey to write the check, because it comes down to paying people and being competitive. When you're talking about these meter wages here, you have to have, and I would also say you need health care, Dave. I understand there's some limitations on that, but everyone's getting some health care right now. My rule is the lowest paid person who works here at the ISD gets health care. A mom ought to be able to take their kid to the doctor. Same way, so you're asking them to work with people like that. You got to back them up. Now, let me go on too. I thought this was about Senate Bill 597, 598. I go back to Section 298, where this outsourcing and privatization was trying to happen. I'm a huge supporter of community-based health. Huge supporter of Macomb County. Took away $40 million and we still survive. It comes down to the closer you are to the folks you serve, the better off you are. I'm not an advocate of centralized planning and somebody in Lansing or outsourcing contracts to some outfit outside of Michigan. And that's what will happen if we lose that. We'll never get it back. Finally, I just say this. I'm okay with telehealth and telecommunication, all that, but not as the first option. My experience is the last 2 years, remote learning did a disservice to all my kids, to all my people right here. So, there's no substitute for in-person, either therapy or teaching. Those are extremely important assets we need to maintain. I'm fine with telehealth being an option for people, but I don't want to see it drift into they don't have the in-person therapy or the in-person consultation, because what will happen is somebody will do a spreadsheet and say, hey, it's cheaper to do remote learning than run a school and have people come in. It's the same kind of, I see it over and over all the time. Those would be my comments. I'm a strong supporter of keeping community mental health as it is. And I've read the literature here and I've seen which groups have lined up against it. And I can't, and right now, when I read the legislative, the analysis, representatives, I'm struggling to find out how it's going to be better. That would be my, and again, I know you didn't ask for this kind of testimony here today, but that's the bigger issue that is bothering me and all the parents I work for here in this county. So those would be my 3 or 4 comments on behalf of my friends here in Macomb. Is that okay, Laurie? Did I embarrass you?
No, that's great. Sorry. Rep. Stone, I'm answering too. This is what we want to hear. That's really helpful. So,
well, and
thank
it's
you,
what
Superintendent.
spurred this on, right? We knew that people were promoting legislation, and we really need people in our community advocating for our needs.
Yeah, that's exactly right. Mark.
Yes, first I want to thank all of you for this and putting this together. I work in the SUD field. I've been working for one of the MCOSA providers for over 10 years. I work with people directly in the community that have a SUD coming out of prisons, in the drug courts. We had to switch to telehealth too, like Dave said, pretty much in a weekend, where we could still engage our people virtually, because the worst thing you can have somebody do newer in recovery is isolate. And they were told to isolate. So we learned real quick. It worked. We still have some people that were doing it. We're doing a hybrid now because we see the importance of the camaraderie and the interaction with people, that they help each other. So we are doing some. We still have some people with limitations. Maybe it's physical, transportation. That's always a big, big, big one, because a lot of the people we work with don't have a driver's license or don't have a vehicle. And I can't thank Dave enough. Him and MCOSA, the stuff they've done to let us expand our programs has just been fantastic. And a lot of this that, Shirky and Whiteford are talking about, they just kind of say SUD and they leave it at that. They don't really give any details. And I think it was Shelley that said, for lack of better terms, the bottom of the totem pole. We're under that totem pole when it comes to SUD services. But MCOSA has been really supportive, providing, funding for our peer coach services. We're in drug courts, we're in emergency rooms now, we're in jails. We started an apprenticeship program to work strictly with veterans. So it's been fantastic, but I just don't want in all this mix to have SUD forgotten about.
Yeah, Mark, I completely agree with you. And that's why at the beginning, we really tried to say, hey, remember, with our system now, this is who we get to work with. And it's really important that none of those groups of folks who we get to work with get lost. So I completely agree. Yeah, thanks, Mark. Laurie.
I don't know. It's probably
Hi.
just expressively. Oh,
Oh no, I'm sorry. I meant Laurie Phillips.
oh, good. I was like, I didn't sign
But
up.
if you have something else to add, Laurie, go ahead. Well, my name is Laurie Phillips. I have a son that's 35 that has used CMH services. He's autistic impaired. My fear is, well, first off, on telehealth, it has worked, but I still believe that he does need to see an in-person at least once every 3 months, just to have, so that mom isn't there and dad isn't there, because then he'll look at me to answer the questions instead of him actually, with what communication he has, be able to work himself with somebody on behavioral issues. So I think telehealth is a good thing, but I don't agree that, again, we've had with CMH services, I just finally saw my caseworker, and it was wonderful to see her. That was mostly my fault, because until I knew everyone was vaccinated and everything, I was leery about those things. The other thing is I agree with Mr. DeVault and everything he stands for, because as he knows, I'm a huge fan of the ISD, and I did work there also for many years up until recently. And I just feel that what is happening now in Lansing, it's not only for my son, it's not only about the state running his health. I can bring together any health care that he needs as a mom. I can coordinate things. Nobody else needs to do that for me. I've done it his life. He's 35 years old. I can continue doing it. And that's scary to me, because I worked hard to get everything in place at this stage of his life. It also scares me that a lot of the services, like if we go to Mr. Shirky's bills, that CLS, is that really medically necessary? I don't know. The respite, is that really something? I know I need it for my mental health sometimes. His day programming that he attends in his workshops, those are things that I'm afraid will be missing for that 26 or 18, 19, whatever they are, that can go into the adult work program. Those are things that need to be kept intact. For him, that's his job. Those are things that he needs. That's his activity. That's his socialization. Again, we're using telehealth for those services right now until everything dies down. And I know he's safe. And I know where he attends will be safe. Telehealth is working now for a couple hours a day. He's going to do it on his own. But those are things that scare me. Those are the little things. It's not that can be taken away from him and everybody that attends those programs, because I don't believe that that's going to be included.
That's really helpful, Laurie.
In the bill that's coming up.
Yep.
Thank you.
Yeah, thank you. That is really helpful. Yep, and you're right. Like that is a huge concern when things move to like in when we don't have access to those additional services that are absolutely part of the care, but not part of a medical model.
Correct.
Yeah. Thanks, Laurie. Do we have anyone else who'd like to talk this evening with us before we wrap up here? Yeah, Shelley.
Just want to take a quick moment to speak a little bit more, as far as what Laurie Phillips said. Thank you, Laurie, first of all, for saying all that, because that is also relevant. Laurie's very familiar with our programs. In Macomb County, In the center-based programs, we probably have about 2,500 to 3,000 students or consumers that ages, like birth to 3 and then 3 to 26 who we service. And those are center-based programs, meaning those are, students who are moderately cognitively impaired, severely cognitively impaired, severely multiply impaired, autistically impaired, emotionally impaired. There's all, lots of different, acronyms. But those are the consumers that I feel, and I'm sure some of us can echo this, that sometimes they are kind of the forgotten, because every one of them sort of has a little bit of a different story, and they don't all require the same services. So it's very hard to write programs or to have a blanket amount or type of services available for them. They need very specialized care. And like Laurie said, if Shirky's legislation goes through, those are the things that we're going to lose. And then we are not taking care of the most vulnerable in our society. And that's what we need to do. These consumers, they deserve this. They should get this care. They should be able to be part of their society. They should be able to have those supports to live on their own if they can, communicate with others, go into the community, learn, educate themselves, and be an active member of society, and be a human. Be treated with kindness and respect and dignity. And that is the one thing that I think Laurie touched on so well, that will go away when this deal goes, if this deal goes through with Shirky. It just, and we are a smaller group, our individuals with intellectual and developmental disabilities. We probably are a smaller group, under that CMH umbrella, but we still need the attention also.
Absolutely. Yeah. Thank you, Shelley. Well, I'd like to say thank you to all of our panelists, to all the folks who gave their comments to us. Thank you so much. Rep Stone and I will continue to work on this together. Brooke has put, again, that Google form in the chat. Please, again, I know I said this, but please send that to your networks. We want to hear as much as we can from folks. And I just want to express my gratitude for your time tonight. I know that can be a burden sometimes. And so I am grateful to all of you for taking the time to talk about this really important issue. And I wanted to turn it over to Rep Stone to close us out this evening.
And thank you so much to Rep Braybeck to take your professional experience and to find this opportunity where our legislature is in much need, and to offer that leadership, not just to your community, but to extend it across the state to all our communities. So much appreciated. Thank you again to your staff and Brooke and the organization. And just being a listener, a fly on the wall for this, it just again reinforces how proud I am to serve in my community and the resources that are available here, and to be able to be a partner and an ally, and to do this. And I do want to end on the note that from the legislative perspective, it is inspiring to have such hearty advocates in our community. And I want to prepare you that if and when we see legislation moving and we need your voices at the table, we will be mobilizing you. And we need you to be prepared to say just what you did tonight, and say that this is what is available out there in our communities, that our community mental health networks are some of the most efficient stewards of tax dollars, and have that individualized provider and care, and be able to wrap our arms around some of our most vulnerable and in need community members, and make sure that we don't lose it. I understand the perspective that they're like, we see what Macomb County has in some of the communities, and we want that in every county. But we don't want to do it at the expense of what's already in place. So we want to invite them in and say, hey, look, this is what's working. This is how we can do it even better. This is how collaboration can help the dollars go farther. So don't just eliminate this for some pie in the sky dream. So just thank everyone tonight. Appreciate, continue to give that feedback. And thank you.